Thank you, Ali. Welcome, everybody, to our breakout session on navigating evolving data needs. This session has been organized by Betty Harney from the Center for Health Information and Analysis in Massachusetts. Go ahead on stage. This session is sponsored by the Milliman Med Insight, a NATO collaborating partner and longtime NATO supporter, and we thank them profusely for their support of our conference and for NATO in general. Betty, I'm going to go duck off stage now and let you introduce our first set of panelists.
Thank you, Norm. I'm Betty from CHIA, Massachusetts. I am the Director of Data Enhancements, and I'd like to thank everyone in attendance here. We heard this morning at the award ceremony that health data is a team sport, and I'd just like to thank everyone who is sticking with us till the very end of this conference, taking one for the team. You will not regret it. We are going to share some valuable knowledge about data usage, data management, data intake. So with that, I'd like to introduce the first presentation. There'll be three presentations, Janine and Brian. So Brian Williams is the Vice President of Analytic Services at Stern Consulting. Janine Molino is the Assistant Professor of Research in the Department of Orthopedics at Brown University, and she's a research biostatistician in the Lifespan Biostatistics Core at Rhode Island Hospital. Welcome, Janine and Brian.
Thank you to everyone who is joining us here today for our discussion of what's out there, developments in navigating the healthcare data universe. I'm David Stern from Stern Consulting. We've been in the health data field for years, and we're following with great interest how that field is changing, and changing in important ways. Specifically, we've seen three fundamental factors driving those changes. First, the sheer magnitude of data. Second, the new technologies that are disrupting how we use data throughout its life cycle. And third, the philosophical shift towards open access and sharing of information. We set out to understand these changes, and particularly how they affect the ways we find, evaluate, and share information. I'll now turn it over to my colleagues, Brian Williams and Janine Molino, to tell you more. Brian?
Thanks, David. The three factors you described are related. The increasing amount of information available to us is due in part to advances in technology for collecting and disseminating data, as well as the shift, and in many cases, the requirement towards sharing data. The underlying question for us is whether the availability of information is outpacing our ability to find and evaluate the data sets most suitable for a particular project. We examined this question from three perspectives: existing resources for finding, evaluating, and sharing data sets, a top-down view from organizations that influence the ways we collect and use data, what we refer to as the authoritative sources, and a bottom-up view from users of data across multiple disciplines. Let's begin with what's out there now. There are several excellent resources for storing and sharing data sets, such as ICPSR, the Global Health Data Exchange, Harvard Dataverse, and others, with varying availability of key features, including documentation on purpose and use, metadata, search utilities, variable level detail, and links to publications. These resources give us a good point of departure for understanding what's currently available. But these are not just passive participants in influencing change. Some are also among the authoritative sources we mentioned that are driving change, and which constitute the top-down perspective in our analysis. And here are those sources. They include three different groups within HHS, with the National Library of Medicine being perhaps most relevant to us. Academy Health, which is the leading national organization for health services researchers, and ICPSR, the Inter-University Consortium for Political and Social Research, which curates and provides access to data from relevant fields. We looked at planning documents from these organizations to see what they had to say about developments in HSR and to get a glimpse of what the future may look like. And in fact, we see that all of the organizations include objectives related to the collection and use of data. Here are some excerpts from the various planning documents. Note the references to harnessing data to improve health, enhanced dissemination, and using the right data and methods. Perhaps more interesting are some of the visions of the future. Here are a few excerpts from the synopsis of the NLM strategic plan. Manual curation is unsustainable. The future lies in curation at scale. Automatic and autonomous databases, machine learning, and a dynamic and interlocking network of research products. These give a pretty good summary of the top-down perspective of what the future may hold. For now, NLM has already made some changes. Based on the strategic plan, it has discontinued some of its offerings while maintaining and focusing on others. Indeed, NLM's National Information Center on HSR has retired 4 of its 8 major offerings, including the HSRRR, its curated list of major data sets. This is an ongoing story which we continue to follow. Of note, as of January 2023, the NIH, of which NLM is a part, will require that all funded proposals include provisions for data sharing, which will contribute to the ever-growing volume of information. So we see the volume of data growing, while existing tools to navigate those data are discontinued. It will be interesting to see what comes next. So that's an overview of our top-down analysis of what's happening in the health data universe. We turn now to our bottom-up analysis, the perspective of actual data users. To get that perspective, we conducted a pilot survey called the Data Selection Process, a survey to determine how healthcare researchers and analysts find data sets appropriate for their projects. We sent the survey to 370 data users and information specialists at public health schools, medical schools, and firms that provide health data or management services. For a breakdown of the results, I'm going to hand the mic over to Janine Molino. Janine?
Thanks, Brian. Before I address the core survey questions, let's look at the key characteristics of our respondents. We received 33 valid responses. 64% of respondents are affiliated with colleges or universities. 94% have doctoral and master's degrees, and professor and librarian are the most commonly reported positions. 70% of respondents perform or oversee research. 30% support research in the role of librarian or other information specialist. The large majority of respondents are involved in health services research, and both secondary and primary data sets are widely used. So that's the background on our respondents. Let's move on to the core questions. We posed 2 core questions. The first deals with how users find data sets. Here's what we found for the group as a whole. Almost 2/3 of respondents know the sources that maintain the data they need and search those websites for specific data sets and variables. Over half use citations and recommendations of colleagues. Fewer respondents utilize general search engine inquiries, dataset catalogs, or the services of librarians or other information specialists. Now, as you might imagine, these findings varied as we broke the data down by respondent characteristics. Here we contrast the results based on the roles of respondents in conducting research. On the left, we have researchers, those who perform or oversee research, and on the right, we have research supporters, that is, librarians and information specialists. The tables are sorted in descending order by the % of respondents using each method. We see some clear similarities in the rankings, but a couple of notable distinctions. Note, the green rows representing the use of dataset, catalogs, repositories, or dedicated search utilities. It's the top method used by research supporters, but ranks second to last for researchers. Looking at researchers overall, we see they show a preference for familiar datasets and datasets from familiar organizations. These results seem to suggest a fundamental difference in how these groups find datasets and has implications for how those interested in expanding access to data engage them. This difference between the way researchers and research supporters find datasets may be the most important finding of the survey. The second core question deals with the need for additional resources for selecting datasets. The question asked, how likely would you be to use or recommend a new tool with certain specific features? Almost all respondents said they would be very or somewhat likely to use or recommend such a tool. This held true regardless of their role in research or any other characteristics. This is interesting in that the prior question showed a split based on research role in the current use of such tools. For more on that and some summary comments, I'm going to send it back to Brian.
Thanks, Janine. We looked at 3 perspectives on navigating the health data universe and found that there are excellent existing resources for storing and sharing data. The future lies in curation at scale with automatic and autonomous databases. And as Janine just noted, almost all of our respondents want new tools to help find and evaluate data sets, but are split on their current use. Our original question suggested that the ability to collect, store, and share information may be outpacing the ability to find and evaluate data sets. Our findings indicate that this may be so. The fact that respondents were essentially unanimous in the desire for new tools to find data sets confirms the need for such tools. The fact that many expressing that wish are not using existing tools suggests that there may be gaps in the current offerings or a lack of awareness about them. So, while we benefit from technological advances in the spirit of sharing that expand the universe of information, the need for tools to navigate that universe will only grow. We look forward to what's to come. Thank you.
Wow. I have a lot of thoughts after listening to that. That was excellent. One of the thoughts that came across my mind as you explained that, Brian and Janine, was the beginning of your presentation, the difference on the perspectives. And from my experience, and I'm not sure about other folks at this meeting, but the perspective, the top-down perspective, is typically the person that's asking for an analysis or a report, and they from the top say, oh, we have all this data, wonderful data, and here's what we want to do, and please go and do this. But the person, like the most of us, I think, that have to actually create the report and answer the request, have to do it from the bottom up. And it's usually that's where the challenge is. Where is the data? How do I link the data? How do I answer this question and meet these expectations from a different perspective? So I just throw that out as one of my thoughts. And then the other piece, which is fascinating about your presentation, is this, difference in how people, whether they use the tools or they don't use the tools. Here's a question for you. What are your next steps in understanding how people find and evaluate secondary data sets?
There's a few things. And by the way, Betty, thank you for the comments. There's a few things we're doing. One of the things we clearly want to do is to follow up on the findings from the pilot survey. And one of the things we did is we had an optional section in the survey for those who wanted to continue on and participate in the discussion to give us their contact information. And we, in fact, got several people who wanted to do that and provided us that information. So we're planning on something like a focus group to further explore that and to get that conversation going. And that should happen sometime in the very near future. Second thing we're doing is we're looking at ways to compare data sets objectively. It's similar to what's being done in the publishing world, where there are established metrics for assessing the impact of journals. And we've done some initial work developing analogous metrics for data sets, and we're going to continue to work on that aspect of it. We're also looking at other research that's out there. And Janine, I think there's a couple of studies that we looked at recently. You might just want to share your thoughts on one or two of those.
Yeah, so we haven't found very much out there at all. There's been a few studies focusing on college-age kids, but we've only found one that looks at faculty level researchers, and that was done at the University of Idaho, and they found similar findings as we did in terms of researchers and how they find their data, and they're typically talking to their colleagues, looking at data sets that they've used before. Sometimes they'll Google it, but they're rarely using catalogs or help of librarians at their institutions.
So one of the things you spoke about was like possible lack of awareness, which I think is a really good point. So do you have any recommendations for improving awareness of these valuable resources, tools?
It's interesting. We found some incidents of specialized resources, focusing on a particular disease or particular condition, which we had never heard about, and we had never stumbled across in doing our own analysis, which we've been doing for quite a while. And we read some papers by them, and they had very much focused their outreach on their own circle of constituents, and they were very well known within that silo of constituents. So it does kind of give us some ideas, some suggestions about how you might expand that. But if you start with your immediate constituents and maybe use some of those lessons to expand it out to a broader audience.
Yeah, and maybe NATO could be, it already is a resource for sharing at a national level. So thank you. Do you guys have anything else that you're thinking that you want to share before we, I don't see any questions from the audience. We might go on to the second presentation. If questions come in, we can look at those at the end, but that was an excellent presentation.
Thank you.
So next up is Onpoint. And we have Devon, Holgate, and Sam Chick. Now, Devon is a director of software engineering, and Sam is an analytics engineering manager. I'm not sure if they're both on, but I know I've been talking to Devon, and so we're looking forward to their presentation. So next up, Onpoint. Thank you.
To processing and presenting big data tips and tricks. My name is Devon Holgate. I'm the Director of Software Engineering at Onpoint Health Data, and I'll be joined by Sam Chick, our Analytics Engineering Manager. Onpoint has over 2 decades of experience working with ABCD data, and we're currently managing about 50 billion healthcare claims records, covering 80 million lives. So in taking on this amount of data, we've learned a few things around how best to process and present that data, and that's what we'd like to share today. So the first tip that I'd like to go through is around leveraging the cloud. So Onpoint is fully cloud-based. We're leveraging AWS. So you'll see a lot of examples of AWS solutions here. That's because that's what we're using, but there are similar tools that you can use with other providers. The tools that we're using for our processing are primarily Spark SQL, which is run on Elastic MapReduce EMR within AWS, and solutions like that typically do a lot of parallel processing and push data to multiple nodes within the system, so multiple servers. And therefore, it's important to have a very scalable solution that can scale up the number of servers to handle an increased load on the system. It's very easy to do that in the cloud. It's much more difficult to do that on-prem, and it's less efficient to do that on-prem because you're either left not having enough servers or you have too many and you're paying for servers that you're not using. So that's what makes the cloud more cost efficient for these types of solutions. And it's also faster because for the same workload, you could have a process that takes 10 servers, 10 hours, and scale that up to 100 servers and get that done in an hour and pay roughly the same amount within the cloud. So that's leveraging the cloud. The next tip is around using the right tools. So 2 pieces to this that I want to go through are around open source standards and column-oriented storage. So there are a lot of open source tools that are becoming more and more popular for a few reasons. One, they're open source, so they're cheaper. But the second is there are a lot of services that are being built on top of these solutions. So it becomes easier and easier to use them. And organizations such as Onpoint, for example, are able to get enterprise level solutions, which includes support from a cloud provider, while getting that cheaper open source software. And this is only going to continue. Those cloud providers love using those open source tools because it makes their solution cheaper, and they're going to keep supporting those, and they're just going to become more and more popular. So my suggestion, or Onpoint's suggestion, is to start using those, start training staff, and leverage those tools that are being built across the various providers. The next tip is around column-oriented storage, and we recommend that you consider using this for your analytic use cases. Column-oriented storage typically is much cheaper because it compresses the data and therefore you're storing less data. And it's also faster, both because you have less data that you're querying, but also because most analytic queries are very much based on selecting some subset of columns to display either in a dashboard or in a query. So Onpoint leverages Redshift and AWS for that column-oriented storage for analytic use cases, and we also leverage Parquet for our core data processing, and both of those solutions make for a cheaper, faster experience, both for our processing and our end users. So those are some tips around data processing. Next, I'd like to hand it off to Sam Chick to talk about data visualization.
Thanks, Devon. So I'm going to walk through now some pointers on how to efficiently visualize and report your data once you have it all processed and stored. No matter what kind of platform you're using to report, I think the most important thing you can do is to put in the work ahead of time to create the right data set that's going to support your reporting. And the first way I think you should do that is to roll your data set up to the highest granularity possible. The math is pretty simple here. Fewer records in your data set means that the reports that use it are going to run more quickly. If you want to report by, say, zip code, but your data is at the person level or the claim level, you want to roll that data up to the zip code level ahead of time. Otherwise, your server is going to be doing that work every single time somebody uses your report. When you're rolling up that data, be mindful of dimensions with lots of discrete values. So something like age has a lot of different potential values. So you want to consider bucketing that into something that's going to have fewer discrete values. So having 5 age buckets instead of 100 plus discrete ages is going to decrease the size of your data by potentially a factor of as much as 20. Similarly, do as many calculations ahead of time as you possibly can. So if you have a measure in your data set that you want to report, like say a loud amount that combines multiple cost fields into one, create that field in your data source instead of in your report. Either you do it once in your database or your server does it every time somebody wants to use your report. Avoid joining or avoid joins in your data sources. Most reporting software allows you and kind of even encourages you to create complex data models in your data sources. If you need to join tables together, though, it's more efficient just to do it ahead of time and materialize that join table in your database. Again, either you do it there or your reporting server does it every time somebody loads that report. Remove any data you don't need. That might seem kind of obvious, but I often find that by the time I've finished a report, I have a lot of fields or records in my data source that I don't need anymore. I think you'd be surprised by how often and how much you can clean up once a report has finished its development cycle. Lastly, consider using an extract, especially when your data source is less than 1 billion rows. That's not a hard and fast number, but it's the one I see cited most often. Extracts can take a long time to create, especially when they have that many rows, but they will make your reports run more quickly. More time spent by you up front, in that pursuit is going to pay off large dividends for the users of your reports. So now that I've covered some of the important things you can do before and after report development, I'm going to cover some tips for improving the performance of your reports as you build them. And if there's a common theme to this section, it's that simplicity is really paramount. Again, this might seem obvious, but the more complex you make your reports, the less efficiently they're going to run for your users. Fortunately, I think there's a lot of ways you can make your reports simpler without making that very obvious or negatively impacting your user's experience. So my first pointer here would be to minimize everything you can. Minimize sheets, minimize dashboards, marks, filters. Fewer things to render means that your reports are going to run more quickly and smoothly. A report with 3 filters will refresh more quickly than one with 10. If you truly need 10 filters to meet your customers' requirements, that's not the end of the world, but it's okay not to have 10 filters just because you can. Not all data types are created equal in terms of dashboard efficiency. Booleans, which are in true, false, and numerics can be processed a lot more quickly than things like dates and strings. The difference between those may not be perceptible in real time for just one single instance, but when you compound that difference 50 or 100 times throughout a large dashboard or report, that can often be the difference between your report feeling very fast and snappy versus feeling laggy and frustrating to use. You want to be mindful of the filters that you're using, not just how many, like I said earlier, but also the different types of filters. Filters that exclude values, for instance, are a lot less efficient than the ones that include values. Going back to my previous point, filters that look at strings or dates are going to run a lot more slowly than ones that look at Booleans or numerics. And it's always possible to create calculated fields to simplify complex filter conditions into a simple true false. So consider doing that if you have a lot of filters and you want to try and condense that down into a single one. Lastly, you should try to avoid calculated fields that reference other calculated fields. We call that nesting. So when you nest calculated fields, it increases the number of times that those fields need to be calculated. It's not always possible to avoid this, but it should set off alarm bells when you do see it happen, and you should be thinking about how you can limit that use of nesting when you see it. So that's just a few things you can do to make your reports a little more performant for your users. It's certainly not an exhaustive list, but those are all things that I've found to be very effective in my own work, especially when working with very, very large data sets. So thank you all for joining us today. Please feel free to reach out to Devon or me if you have any further questions, and I will turn it over. Thank you.
Wow, that was excellent. As someone who did a lot of programming in the beginning of my career, I don't know about other people, but I felt like I was in class and learning about the best practices and being reminded of things like minimize and simplify, which is fabulous because everyone needs those reminders. So I appreciate that you actually thought that out, documented it, and then shared it here with all these data folks. For me, this concept of minimize and simplify is so important. And we feel, growing pains here in Massachusetts as we build out the enhanced APCD. And, we have experienced a lot of questions about how do we optimize, how do we make it more efficient? So this really does help to be reminded of these tips. I'm not sure if there are other states that would like to share some of their growing pains, but we've definitely, dealt with a lot of these efficiencies already in Massachusetts.
Thanks for saying that, Betty. Yeah, I find that sometimes the challenge is finding the time to go back and simplify. You always want to move forward, but if it's something that's very important that everybody's looking at frequently, it does sometimes make sense to go back and really enhance that process over time. Yeah,
because sometimes you can get attached to your code or your complexity, or as you said, like nesting things within, you can become so proud of your, fancy algorithm, but it's actually not a good practice. And to have to delete it or redo it, people, it bothers people to do that. I don't know if there are any other questions. I don't think so. If not, we can let people type stuff in and move on to the CHIA presentation, which is our third presentation by Christine Loveridge and Brian Beaman. Christine is the manager of research here at CHIA. I'm in Boston today. And Brian is a senior research analyst. I think I've seen both of them. They're here in the building somewhere, and I think they're excited to present their findings on outpatient observation, and I'm thrilled to hear about their hard work and their results.
Good afternoon, everyone. My name is Brian Beaman, and I'm a senior research analyst. Presenting with me today is Christine Loveridge, who is a manager of research. We're both from the Massachusetts Center for Health Information and Analysis, or CHIA for short. Our presentation today focuses on the evolution of outpatient observation visits and the use of observation data in Massachusetts. Our presentation will first provide a brief background on the clinical and policy background on outpatient observation visits. Next, we'll discuss CHIA's approach to collecting outpatient observation data in our case mix databases. Following that, we will discuss the use of outpatient observation data for analytic purposes and end with some concluding remarks. So there's a continuum of services that are provided by acute care hospitals. Inpatient and emergency department services are among the most common visits whose data are collected and reported on. Other visits, such as outpatient observation visits, outpatient ambulatory surgeries, and other outpatient services are important parts of the acute care hospital setting, but are less consistently reported on, and data collection varies widely. Today, we are focusing on outpatient observation visits. In the clinical setting, observation visits can serve a variety of functions, including the assessment of patients who may require additional diagnostic or therapeutic treatment beyond care in the emergency room, but may not require admission to the inpatient setting. Observation visits, like ED visits, are classified and billed as outpatient care. But from the hospital and healthcare provider's perspective, these beds may occupy some of the same beds used for inpatient stays and sometimes may seem to the patient as an inpatient visit. Common diagnoses suggest that many patients in observation show symptoms that may require care in the hospital setting, but did not require an inpatient admission for some reason. Observation visits are an important part of the hospital setting, but it is also important to recognize the role that health policy has played in shaping how hospitals utilize outpatient observation. One of the major acknowledgments of the role of observation visits occurred in 2003, when the Centers for Medicare and Medicaid Services, or CMS, first recognized observation visits, offering payments for some common diagnoses associated with observation, including chest pain, heart failure, and asthma. In 2012, CMS implemented the Hospital Readmissions Reduction Program, which penalizes hospitals for higher than expected Medicare readmission rates for certain discharge diagnoses. In 2013, CMS implemented the 2 midnight rule, requiring physicians to attest to the medical need of a minimum of 2 nights to justify billing the admission as an inpatient stay. In our approach, we wanted to consider how other states collect and report case mix data. Most states with case mix data voluntarily report inpatient and ED visit data to the Agency for Healthcare Research and Quality, or AHRQ. Some states also report ambulatory surgeries and other outpatient care to AHRQ. Outpatient observation visits are not collected as a distinct database by AHRQ. Massachusetts is one of the few states to collect observation data as a distinct database. Next, I'm going to focus on CHIA's case mix databases. CHIA, as an agency of the Commonwealth of Massachusetts, is responsible for collecting and maintaining the Massachusetts Acute Care Hospital case mix databases. The case mix data includes detailed information from acute care hospitals, including patient demographics, admission and discharge information, diagnostic and procedural coding, provider details, charge information, and much more. The case mix data includes detailed information on different types of hospital visits, including inpatient discharges, which are found in the Hospital Inpatient Discharge Database, or HIDD, outpatient observation visits found in the Outpatient Observation Database, or OOD, and emergency department visits, which are found in the Emergency Department Database, or EDD. And CHIA has been collecting this data for over 20 years. So CHIA uses the following data submission flow when classifying hospital visits into the Massachusetts case mix databases. If a patient was admitted to the inpatient setting, they'll be found in the HIDD. If a patient was in observation but not admitted, they'll be found in the OOD. And if a patient was seen in the emergency room but not admitted or observed, they'll be found in the EDD. It's important to note that this flowchart does not reflect the pathway of care patient experiences in the hospital setting, but rather how an acute care hospital record is classified. And now I'm going to turn it over to Christine to discuss some key findings from our report on outpatient observation visits in Massachusetts.
Thank you so much, Brian. So as Brian mentioned earlier, I am Christine Loveridge. I'm a manager of research at CHIA. In January 2021, CHIA published its first report on utilization and trends in outpatient observation visits in Massachusetts, covering federal fiscal years 2016 through 2019, with some trends going back as far as 2006. This is the first time these data have ever been reported in a systematic way like this in the Commonwealth. This report complements other recent CHIA reports on acute care hospital utilization that focus on those other settings of care in the acute care hospital setting, inpatient visits, emergency department utilization. On this slide, you can see the total volume of outpatient observation visits in the Massachusetts case mix databases. The blue bars are the outpatient observation visits that were associated with an inpatient admission. That is coming from the HIDD. And the orange part of the bars are those that are not associated with an inpatient admission, that is coming from the OOD. Overall, about 1/3 of observation visits were associated with an inpatient admission in the most recent data year I'm showing here, which is federal fiscal year 2019. In that year, there were about 330,000 total outpatient observation visits in the Commonwealth. That is up about 50% from 2006, although growth has leveled off since about 2017. Although not shown here, internally, we do have more recent data for federal fiscal years 2020 and 2021, which has shown steep declines in volume, consistent with the observed drops in volume that we've been seeing in other components of acute care hospital services during the pandemic. Also not presented here, but it is very important to note, the vast majority of outpatient observation visits, nearly 90%, began with care in the emergency department. Next, on the next few slides, I'm going to discuss some characteristics of these observation visits. So for the next 3 slides, I'm going to focus on just those observations visits coming from the OOD, that is those that resulted in discharge from the observation setting, not associated with an inpatient admission. So in this graphic, you can see the proportion of observation of visits by hospital characteristics, including hospital cohort, high public payer status, and multi-hospital system affiliation in FFY 2019. The majority of all outpatient observation visits were from community hospitals, and nearly 45% overall were from community hospitals that had a high public payer or HPP designation. CHIA defines HPP hospitals as those receiving 63% or more of their gross patient service revenue from public payers such as Medicare or Medicaid, regardless of what hospital cohort they belong to. Hospitals and hospital systems also vary quite a bit in the extent to which and how they use observation visits in their continuum of acute care services. So for example, the largest healthcare system in Massachusetts by inpatient and emergency volume was Partners Healthcare, now known as Mass General Brigham, but that system made up a much smaller relative share of visits in the observation setting. Next, in this graphic, we see the proportion of visits by patient and visit characteristics, including the expected primary payer type for the visit and the age group, gender, and race and ethnicity of the patient. We see that the most common expected primary payer type for observation visits in Massachusetts was Medicare, followed by commercial insurance and then Medicaid. By age group, you can see that over half of all observation visits were among non-elderly adults aged 18 to 64. Elderly adults aged 65 and older represented another 40% of visits, and children represented just 8.8% of observation visits. Interestingly, the share of visits for female patients exceeded that of male patients by over 10 percentage points, due in part to hospital visits for maternity-related conditions. All right, this slide shows the top 10 primary diagnosis categories that we see in observation visits. For this slide, we're grouping diagnoses using the clinical classification software Refined tool from the Agency for Healthcare Research and Quality. By far, the most common primary diagnosis was nonspecific chest pain, comprising 13% of all observation visits in federal fiscal year 2019. Other common primary diagnoses across all observation visits include syncope, which is fainting, abdominal pain, and cardiac dysrhythmias. We also observed substantial hospital-specific variation in the distribution of diagnoses that we're seeing, reinforcing the point that hospitals do really vary a bit in how they're using this setting of care. Okay, and with that, I'll just quickly recap a few takeaways from our presentation. First, we discussed that outpatient observation visits are a distinct type of care within the broader acute care hospital setting that hasn't received quite as much attention in healthcare services research as other components of acute hospital care. The scope of services provided in the observation setting often overlaps with services that may be rendered in the inpatient setting, but from a billing perspective, observation visits are billed as outpatient encounters. Massachusetts is fairly rare among states in that it routinely collects data on observation visits that don't result in inpatient admissions. Looking at our data, we found that the vast majority of observation visits start in ED and about 1/3 end in inpatient admission. but the extent and type of usage of this setting of care varies widely across acute care hospitals and hospital systems. CHIA now has data internally on these visits through the end of federal fiscal year 2021, and preliminary analyses show a large drop in utilization in the observation setting, in parallel with drops in volume that are observed in other components of acute hospital utilization during the COVID-19 pandemic. Moving forward, the agency is going to continue to monitor patterns and trends and how hospitals are using this important setting of care. Thank you very much.
Wow. That was wonderful, Christine and Brian. You did an excellent job. And, you know, considering we're all CHIA, I just have to give you special kudos, not only to you guys, but to the other folks that hopefully are on the line from CHIA that were involved in the collection efforts and the data management efforts to get this data in the door and make it usable so that you could create this wonderful report with all these findings. So kudos to everyone that worked on this at CHIA. The other thing that I just want to say as a CHIA representative, one of that I see that has made this successful is that I know that we have invested a lot in the relationship building with the data providers. So in your presentation, you talked about like that from the acute hospitals, we're collecting multiple data sources and we have the standalone outpatient. But that is because of those wonderful relationships that have been built over many years with the hospitals, the providers of the data. So kudos to everyone here, all the leaders in our senior team that have made that relationship building a high priority. So I had a follow-up question, couple on this presentation. How can other states incorporate information from observation visits in their data collection, monitoring, and reporting of hospital utilization?
Yeah, absolutely. I think that's a great question. So there's, I think there's a few levels that you can attack that at. So the first, obviously, to get that information in the first place, as you were highlighting, Betty, it is so important to have those relationships with your data providers to begin with. Observation data is stored, typically in the hospital's billing systems, the same hospital billing systems where they're going to be pulling information for inpatient visits, for ED visits, other components of acute care hospital utilization. But if other states or the vendors who they work with are interested in collecting that data, it is a matter of going back to those providers and having those conversations to say what is actually feasible to collect from your data. In the case of CHIA, we have hospitals actually flag on every inpatient record, on every ED visit, a sort of self-reported flag for those records that contain observation services. That's sort of one technical path that you can do that. It's just a self-reported indicator flag that they can develop internally and deliver. There's also there are other components that you can use to find additional observation services and visits. So you can look at the revenue codes. You can look at the source of admission flag. In the case of inpatient visits, at least at CHIA, we have a source of admission that is, for inpatient admissions, a source of admission that is the observation setting itself. So there's a few different places you might be able to look in the pre-existing data that you might be collecting through other case mix streams to begin with, since the vast majority of states do collect, at the very least, inpatient and emergency department data. So if you are interested in sort of expanding to those observation visits and rounding out, the data that you're already collecting with these additional fields, especially for those visits those observation visits that don't get associated with your inpatient or your ED visits, you do have those sort of options of working with providers trying to collect that data. So I think, stepping back though, it is ultimately about those relationships and building those with your providers, and as well as technical collaboration. So asking the agencies who have already been collecting this data and have that experience, what are the things that we should be looking for? That cross collaboration is so important for us to be learning from each other as we as we get our data to be better and stronger over time.
So what seems really important is this idea that does it end up in an inpatient stay? Because the way we're doing it in Massachusetts is that if they're in there for chest pain, someone has chest pain, which is the #1 in 2019, and they go to the emergency room, they don't know whether they're going to be admitted for an inpatient stay or not, right? So at the point of admission, it's not clear. And then, so I guess it's kind of the after, or at some point it's figured out that maybe they're not going to be admitted. So then that becomes submission under the outpatient, right? But if they are admitted for the chest pain, then we get that submission in the inpatient. And I'm sorry for my ignorance. I'm just kind of talking this out because I think it would help some of the people on, listening.
Yeah, absolutely. And there's also other routes of patient care, right? So a patient could come in for whether for a scheduled or an unplanned inpatient admission and get admitted, and then ultimately be transferred, sort of step down into the observation setting as well. So it's not just a sort of a holding pen when a patient comes into the emergency department and they're not really sure which whether that patient needs to be admitted or whether they're safe to send home, right? Although that is clearly a pretty large component of what we're seeing. And it was mentioned in our presentation, although I was flying through a lot of things very quickly. Hospitals do a lot of very different things with these visits as well. So we are seeing, some hospitals using these for a lot of behavioral health patients. We're seeing some hospitals using, a lot more of these more traditional, heart conditions, abdominal pain, those sort of things. And it really, it really varies a little bit by hospital. And, when you compare their sort of overall volumes, so inpatient volume or ED volume compared to their observation volume, some hospitals are using this observation setting quite a lot, and some not so much.
Okay. Yeah, that's really helpful explaining that. Thank you. And you did say that at the end of your presentation. I heard you, so about the variation. So one other question. How have financial incentives surrounding payments impacted how observation visits have been used? So talk about the financial incentives or what if anything, about that.
Yeah, so I can talk about that. So one of the biggest ways that hospitals respond in terms of like their types of care and utilization is sometimes payment. So one of the policies we discussed in the presentation was from Medicare in terms of the 2 midnight rule. So it was put in place to better categorize for telling hospitals what warranted an inpatient stay versus an observation visit. So inpatient visits get paid by Medicare Part A, which has higher reimbursement rates, whereas outpatient visits like observation visits get billed under Medicare Part B, which has lower reimbursement rates for hospitals, and can also result in co-insurance driven costs incurred by the patients, given that they may not have a supplemental insurance plan. So payers will be incentivized to limit more expensive types of care, whereas hospitals will be more incentivized to maximize reimbursement. So the nature of observation visits in particular do this kind of this middle ground of observation between ED visits and inpatient visits has had potential to respond to the impact of payment, in addition to just general changes in utilization and disease trends and severity in the acute care population.
Okay. Thank you, Brian. I have to check to see questions, and it looks like there are questions. I'm sorry. I'm just going from the bottom up. I see Sylvia, who's one of our CHIA fellow co-workers. Hi, Sylvia. To what extent have acute care hospitals used observation stay for step down, which we talked a little bit about, to discharge a patient to observation stay where a patient might die, and as a result, the hospital's inpatient mortality rate is lower, as we have seen with the increase in patients discharged to hospice beds? Well, that's quite a long question, but it is about patients dying. I don't know if you guys can see that question, Christine and Brian, or if you can have some initial response to that.
Yeah. So one of my initial thoughts is that, so if they're in the inpatient setting, regardless of whether or not there was observation associated with it, they're going to be in our inpatient discharge database. So whether or not we do collect data on in-hospital mortality. So even if they were in a step down, we'll still see what their disposition was, whether they were released from the hospital or if they died within the context of the hospital.
Right, and I don't believe that the ultimate discharge setting is a reason why they would be excluded from at least our own readmissions reporting, and I believe the same is true of the CMS readmission measure. That those would not necessarily be excluded from the sort of denominator of hospital visits when calculating things like readmissions, as opposed as for the overall mortality rate. I'm not sure. I mean, it depends who's calculating it and how they define that measure.
Yeah. I think another thing is that in recent years, we started including on both the inpatient and the observation databases, specific admission and discharge times from the ER. So if they went to the ER, but were admitted or observed, we'll have those specific times. But we don't have on the inpatient discharge database right now, like observation timeframes, I don't believe. So right now we're not able to see if they were observed then admitted or admitted then stepped down.
Right. We don't typically collect the order on the discharge itself. Theoretically, we could attempt to ask for that. I'm not sure what the provider response would be on that front. We have in recent years been, collecting emergency department entry and exit times because there have been a number of analytic, research needs for that. So, I imagine it would be a similar process, but that would be, a separate effort that we would have to make with the providers.
Yeah. Thank you for your response. And I just recall from my limited experience with this that the time of admission and discharge becomes critical with these collections. So for people that haven't done it, and I don't know if you guys want to speak to that at all, about collecting not just the date, because the stay could be less than a day. So if you want to track how many hours, that's where the time attributes come into play.
Yeah, absolutely. We are certainly interested, not just for the OOD setting, but across our case mix settings in the amount of time spent in the hospital and how visits, how any kind of hospital encounter can vary by the time patients are coming in the day and the total hours that they're spending in those different settings of care is something that we're interested in general, but have only begun to start looking at.
Okay, I just have a couple other questions. Joe Porter, hi Joe. The observation stay work is really interesting. Do you have any sense if the coding of those are any different based on payer type, where the payment for those might be different?
I think we do report on like the distribution of the expected primary payer type. I don't think there were any major anomalies or differences, especially in comparison to perhaps the inpatient setting. I think it was kind of just in general, the population was what we might expect from the acute care hospital setting.
Yeah, I mean, and it depends what you mean by coding, right? So I don't think that there's strong differences in, say, the number of diagnoses codes that are going onto these records by what payer type they have. And we certainly wouldn't be able to do a lot of teasing out of differences in patient demographics and so forth, because there are natural differences in those underlying patient populations to begin with, and saying that, the observation setting is disproportionately this compared to the general, these Medicare patients as opposed to the general Medicare population would be a very difficult analysis to achieve. But, I don't think we have noticed specific differences in the records that we're seeing by payer type. Beyond what you would expect given the populations that they serve. But that would, certainly be something that could merit additional analysis.
Okay, thank you. Now, Mel has a question regarding reductions related to COVID. From your preliminary results, are you seeing a uniform reduction? But the only thing I would say just is that you presented your data up to 2019. So yeah, it is preliminary. You may not know. I just kind of want to give you that out. But if you have anything that you want to share or feel comfortable sharing at this point, we're happy to hear.
We did some early reporting and also some preliminary reporting for the inpatient setting, but I think in general our look through the data, especially for the ED setting and the observation setting, is that due to COVID, there was just a decrease in overall utilization in the acute care hospital setting, which we see across all types of care. This is a response to the pandemic, just less visits to the hospital, especially in particular during peak pandemic times, peak pandemic waves.
Right, and I mean, you do see as expected that on average, the hospitalizations that are continuing during those peak pandemic waves are going to be higher severity visits. So, less able to be canceled or delayed or postponed, fewer elective surgeries or no elective surgeries during the pauses. And so that ends up, since, a third of observation visits are going to be associated with inpatient, you will see a lot of the same trends in the observation setting. But I think, perhaps the ED setting is going to be the better point of comparison. We don't have those data published, but they will be coming in a few months' time about the ED setting and changes there. So since 90% of observations are going to be associated with the ED visit, what happens in the ED really does affect what you'll see in observation as well.
That's right. Okay, I'm sorry, but I'm just watching the clock. So I think we got to bring back the group, and we may have a question for Devon. So thank you, CHIA, again, and if we could bring back the larger group. There we go. So Mel sent us a question for Devon. It said, I would like to learn more about column-based storage. What resource or white paper can you recommend? That's an excellent question, which I'm sure we all could benefit from the answer. So,
yeah, thanks for the question, Mel. I don't know if I have one white paper I would point to. I do know, at least for the big data processing, Cloudera, which was a pioneering vendor a few years back, did have some stats that compared Parquet, which was a format that I mentioned earlier, to some other open source standards at the time, and against CSV files, showing how different the compression and speed of working with that was. I'd say in general, any cloud provider is going to offer column-oriented storage. I would look at what they have for their stats for those services. They're all a little bit different. Some leverage additional technologies on top of just the column storage, so in-memory storage and cluster-based approaches. Hopefully that helps.
Thank you for sharing that. And we have, I think, 1 minute left. Is there anyone thinking that there's something that they wanted to say before we close out? And again, thank you to everyone for remaining open and curious as we get towards the end of this conference. We've learned so much, and I appreciate your curiosity and your willingness to take one for the team.